Hello, ladies and gentlemen. Thank you for joining our e-seminar today. We're delighted to have Dr. Carl Mattacola and Dr. Jennifer Howard from the University of Kentucky sharing their expertise in the area of functional knee assessment. Before we get started, I'd like to tell you a little bit about our speakers. Dr. Mattacola is a professor in the Department of Rehabilitation Sciences in the College of Health Sciences at the University of Kentucky. He serves as Director of the Rehabilitation Sciences Doctoral Program and the Division of Athletic Training. Dr. Mattacola is highly experienced in evaluation of lower extremity pathology, function, and postural control as they pertain to injury and rehabilitation. His research efforts have particularly focused on the assessment of human function, postural control, and strength following injury and subsequent surgical procedures. Dr. Jennifer Howard is an assistant research professor in the Department of Rehabilitation Sciences and the Department of Orthopedics and Sports Medicine at the University of Kentucky and has been a certified athletic trainer for 8 years. Dr. Howard's primary research emphasis is evaluation of clinical outcomes following knee surgery. She has examined methodological considerations regarding the effective response shift phenomenon on patient-reported outcome scores and examine the relationship between performance-based measures of function and patient self-reported function outcomes following articular cartilage repair. We welcome both presenters to our virtual meeting room today. Without further delay, I'd like to turn the presentation over to Dr. Mattacola and Dr. Howard. Dr. Mattacola, the presentation is yours.
Thanks, Teresa, and welcome, everyone. This is certainly the first time that I have participated in the web seminar, so I will give it my best. And thank you all for participating. We are going to do several things. We're going to talk through some general functional assessment tools that we have used specifically related to the neurocom, and probably most often using the long force plate, the balance master. And I'd like to spend a little bit of time going through some general assessment techniques that we have considered and that we have used in the laboratory, talk a little bit about some clinical techniques and some clinical tests that we have used, and then specifically go through some of those tests with you, provide some reliability values, and then Jennifer and I will switch on and off and present some data that we have collected in patient populations using this, and try to give you some suggestions, or at least what we are finding have been some of the more useful dependent variables from these tests. So again, thanks for your attention, and if there are questions, I think we're holding those to the end, and we can try to address as many of those at the end. What I wanted to do at first, and one of the things we've done at UK, is we've begun to talk about our research using 3 terms. That is sort of a PCL model: patient, clinical or clinician-based, and laboratory-based. And I want to overview just quickly some of the techniques that often can be combined either from a laboratory setting that may or may not be available in most clinical settings, and vice versa. And one of the ones that you all are familiar with is obviously isometric strength and the use of handheld dynamometers. We've done several studies with the use of handheld dynamometers. The advantage are they're relatively inexpensive, they're easy to use, and it does provide a measure of strength for comparison, particularly post-rehabilitation, which I guess I should say is much of the data and information we're talking about today has been specific to patient populations related to the knee, and in most cases pre- and post-surgical assessments using these devices. Obviously, there are lots of other orthopedic opportunities to use this equipment, but today we're going to mainly present and focus on some of the work we've done with the knee. So going back to isometric strength, handheld dynamometers are useful, relatively inexpensive, and do provide some information specific to strength assessment. Isokinetic dynamometers provide the opportunity for the patient to exert as much force as they can, and typically most isokinetic dynamometers have a preload or a max load that the patient can't overcome. Velocity is controlled, so the methodology is that velocity is controlled throughout the movement, and the patient would push as hard and as fast as they can, and you would get a measure of muscular strength from that device. Positive of it is that the patient usually can't overcome it. The stability of strapping the patient in is usually very good, so there's less examiner error like you would have with handheld dynamometry. They are expensive, and obviously over the years they have fallen in and out of favor. And I know at least in our institution, they're not used as much as they used to be, and one of the challenges we've had is that they often, or we have found them to be a very useful measure of strength, where some of the other techniques that we're using aren't specific to quadricep strength. So even though they are expensive and often not used as much, we found them to be relatively helpful. In addition, I don't know how many of you are familiar with, but there are some other devices out there that combine both isometric, isotonic, and isokinetic, and the DTE is one of those. And the advantage of this device is that it does provide the opportunity to add functional movements. So because the angular head moves up and down and rotates, there are a lot more options as far as sport performance and functional movement patterns that can be obtained using this device. The other laboratory measure that we have used quite a bit, obviously, is EMG, which is a measurement of a myoelectric event associated with a muscle contraction. And we have specifically looked at the amount of time that a muscle would be on during a given time period, or said another way, the time that a muscle the activation level would be above a certain amount, and how long that muscle would be activated during the activity. In addition, we have spent some time looking at onset, amplitude, and the initiation of muscle activation relative to some event. Obviously, provides some important information specific to the muscle and the motor unit, and sometimes can be time-consuming if you're thinking of it from the clinical setting. So most of these that I've talked about, other than the handheld dynamometry, may or may not be something that's found in most clinics, so I would label it as a laboratory measure. Kinematic assessment is a study of motion, and that is typically done several ways, either with a video camera system or often with something called an electromagnetic tracking system. Kinematic measurements are accomplished by tracking the displacement of specific body segments during motion. Typically used, again, using high-speed cameras. In addition, some kinematics can be integrated with electrogoniometers and accelerometers to provide additional information relative to the movement type and speed. One example Jennifer has used in some of her research is an electromagnetic tracking system. And just to give you sort of an overview, these are called little birds, or electromagnetic transducers, and there's a receiver unit that's at a certain distance away from the patient or the subject. And by integrating and telling the computer where these birds are, you can recreate a three-dimensional system and follow those in space to give you a representation of range of motion at the joint. Most of you are probably more familiar with video analysis for the study of kinematics. Advantage is it's very accurate, however, they're very expensive. Often you'll find 6 to 12 to 18 cameras that are used to assess motion, which are often expensive, as well as it's a complicated setup. So it does provide some valuable information and some specific information at the joint and relative to moments. It's often not very feasible in the clinical setting. I don't know if you can see this. I can't on my screen, but it was just a picture of a person standing with a marker on their shank. And what I was trying to bring across is that using 2D analysis, now just using a video camera in the clinical setting, is actually pretty feasible to look at some joint angles and range of motion. And it's as simple as taking the video and drawing the segments and going back and comparing. Kinetics is another method that we have used quite a bit, and that is, in essence, studying the forces that cause movement and the resulting energetics, and commonly used with force platforms. Specifically, we have studied peak force, time to peak force, and impulse, and there are different types of force platforms that can be used. The Neurocom is one type. The one that's in the picture is a little heavier duty, which would allow a greater amount of force for jumping activities. So the majority of those would be what I would label laboratory measures that may or may not be feasible. What I think are important is you start to think about the assessment of function following surgery, specifically at the knee. Some additional clinic-based measures that we've used is the four-square step test, which you'll see actually later in the presentation follows out as being pretty useful for some of these patient populations, and it's a relatively easy test to do. All you need is several PVC pipes, a stopwatch, and you have the person step into each of those squares, going from 1 to 2 to 3 to 4, and then back, and you would monitor the amount of time that it took them to complete that. So it's a nice test for agility and coordination and speed. In addition, we've also used the STAR Excursion balance test, which again is something that can be performed in the clinic relatively cheaply. You need a tape measure, some tape, and you have the patient stand unilaterally on one leg, and they would reach either forward, sideways, or behind them as far as they can, touch down, and then come back to a controlled setting. And based on the work of Hurdle and Gribble and others, they have determined that instead of doing all 8 directions, that if you do the anterior, posterior lateral, and posterior medial direction, you'll get a representative assessment of someone's lower extremity function, balance, and strength. So this test could require strength, balance, and as well as range of motion. We spent some time looking at balance and postural sway using the surround as well as the long force plate, and the advantage of this, particularly with the Neurocom, is you can often incorporate EMG assessment as part of the process. So you can look at the myoelectric event as well as their postural stability during different conditions. Getting on to today what we're going to focus more on is using the long force plate for functional assessment. So the long force plate is part of the balance master system, has 4 transducers that are in either corner of the force plate, allows some functional assessment, but isn't at the higher level of some of the piezoelectric force plates where you could take a heavy load or have somebody land on them, for example, from a jump. One of the things we'd like to do today, after I go through these tests, is provide you some of the reliability values that we have either determined in our laboratory or that we have pulled from the literature. So at the end of each of these tests, I'll have a slide that lists reliability value, and it came from either one of 3 places: the Neurocom Clinical Operations Guide, a paper by Naylor and Romani, which studied a group of active females for the step up and over, forward, lunge, and squat, and some of our own data, which was specifically obtained from articular cartilage patients. I'd like to quickly go through the following tests that we're going to use in some of the information that we're sharing with you from our laboratory: unilateral stance at the stand, weight bearing squat, walk across, step up and over, and lunge. Unilateral stance is exactly what it says. The patient would stand on a single limb, typically a 10-second test with the eyes open and eyes closed, and the variable of interest is center of gravity of sway velocity. The reliability has been reported to be, I would say, average to moderate to good. The reliability from the Neurocom systems manual is 0.35 to 0.50, and some of our own reliability is in the 0.7s, indicating that it's a relatively reliable test, both with eyes open and eyes closed. I'm just going to review this quickly for most of you. So I'm assuming many of you have already used this equipment and are familiar with it. If not, a quick review. The unilateral stance are several dependent variables Mean center of gravity sway velocity that you typically get with a presentation of it for eyes open and eyes closed. And in this example, the individual, and typically the gray area that you see would be the standard deviation relative to a normal population. So this person with their eyes open, the neurocom will indicate that it's green. They're within the normal limits relative to an age-matched group. And in this case, there was less sway velocity on the right leg versus the left. And again, sway velocity would be similar to a golf score. The lower the score, the better. In contrast, for this example, when this person closed their eyes, their sway velocity increased significantly, and they were outside of their age range. Interestingly, there was no difference between sides in this case, but they were unilaterally or bilaterally poor. Trying to look at comments. So I guess I'll come back to comments, Teresa, or should I be looking at those as I'm going through this too? I'll come back to, I guess, some of those. The sit to stand is another measure we've used. And there are several dependent variables that are picked up or that are indicated with the sit to stand. One is the weight transfer time, which is the time from the onset of the cue to move into the weight is accepted. Another dependent variable from the sit to stand is rising index, which is the force produced by the legs to rise and achieve full standing. And this is expressed as a percentage of body weight. In addition, sway velocity is calculated after the person stands. Once the person rises, they would stand for 5 seconds, and sway velocity would be calculated in the same way it would be for a unilateral stance trial. And again, the greater the patient's sway velocity, the greater the instability. So the higher the sway velocity score, that's 4. Decreasing sway velocity scores show improvement or increased stability. And symmetry is the relative amount of weight borne by each leg during the rise to stand and for the first 5 seconds after the rise. So the sit to stand, after 3 trials, you'd have the time transfer, the index, and center of gravity sway velocity while they were standing. In addition, it will calculate a left and right weight symmetry. And in most cases, for the neurocom, the symmetry line is going to deviate towards the side of greater weight bearing, in this case, to the right side. Reliability values for the sit to stand are good. So based on neurocom, 0.48 to 0.58 for weight transfer. Rising index is probably the best or most consistent. And center of gravity is actually pretty good in the 0.6s and 0.7. And that's actually, having done some balance work, that's pretty good considering the variation that takes place in everyone's balance. Weight-bearing squat, the ratio provides a ratio of the amount of weight on one side to the patient's total body weight expressed as a percentage. And this is typically conducted under 4 conditions. So the standing at approximately 0 degrees in the extension, 30 degrees, 60 degrees, and 90 degrees. And it provides a comparison of the weight that's borne on each leg. And we've actually found higher reliability values when the patients are closer to 90 degrees, but the remainder are okay. I would, those 0.4s and 0.3s, I would say, are pretty good. The walk across is exactly what it says. The patient would walk across the force plate, and there are several dependent variables that are calculated: mean step width, mean step length, so the distance between successive steps, and those are all measured in centimeters. The speed, which is the average velocity of the forward progression, expressed in centimeters per second. In addition, it will calculate a step length symmetry, which is a comparison of the right and left sides. And again, that symmetry bar would deviate towards the shorter step. So when the patient walks across the force plate, you'll get the step width, step length, their speed in centimeters per second, as well as a percentage of step length symmetry comparing the right and the left. We don't have values for reliability from the neurocom. However, some of Jennifer's work, the reliability value or intra-class correlation coefficients, which would be synonymous with reliability, range from 0.68 to 0.96. The last two I'm going to present are the ones we've probably used the most, and I have found pretty helpful as far as comparing some of the dependent variables to patient outcomes, and that's the step up and over and the forward lunge. So again, performed on the long force plate using a 20 centimeter box. The patient would step up onto the box, swing their leg over, step down, and then try to stay as still as they can once they came to a stop. And the dependent variables that we'll talk about are lift-up index, impulse index, and the time that it takes. So the mean lift-up index is the average maximum force exerted by the step-up leg, and that is expressed as a percent of body weight. So as they're stepping up onto the box, it's the force they're exerting by that leg as they're pushing their body weight up. Typically, you take 3 trials for each leg and then sum those to come up with a final score. So the output for the step up and over is the lift up index, the amount of time that it took, and then the impact index, which I'll describe in the next slide or two, is the amount of force that's exerted with the lagging leg as they step down. The mean movement time, before I get to the impact index, is the average amount of time it takes to complete the step up and over, which is expressed in seconds, so it's pretty self-explanatory. The impact index is the average maximum force transmitted through the lagging leg as it lands on the surface, and that also is expressed as a percent of body weight. Reliability for this is pretty good. 0.68s to 0.92s. We found 0.92s in ACI patients. Mailers was active females. And the R value, the regression equation that you find in the neurocom guide is approximately 0.68 to 0.91. Forward lunge, the patient stands at the end of the force plate, reaches forward as far as they can, and as quickly as they can, performs the lunge, comes back, and then stops in place. Those are the directions that you provide. And the dependent variables are reach distance, movement time, and impact index. Mean distance is the average length of the forward step, and that's expressed as a percent of body height. The mean distance difference is a comparison of the mean distance between the left and right legs. So it would give you a comparison of the right and the left leg as they perform the lunge. And the impact index is the average maximum force transmitted through the lunge leg as they land on the surface. So that'd be the amount of force as they landed and pushed up during that initial lunge phase. And then it also provides the difference between limbs. I'm going to skip through a couple of those and just take you to the screen. So the forward lunge provides you the distance and the comparison between limbs, the impact index, which is the impact as they're pushing up the landing, and then the contact time and the force impulse, which is also can be compared between right and left limbs. And I'll talk a little bit more about this as far as the interpretation when we get to some of the data that we found from patient populations. The last definition of this is the average amount of work performed by the lunge leg during the landing and thrusting phase of the movement. So that's the mean force impulse. So it's the amount of work during the landing and thrusting phase of movement, and again expressed in weight and seconds and time. The reliability or consistency for the forward lunge is actually pretty good. So for a good majority of these functional tests, if you're retesting a patient, you can be assured that the reliability is actually good, and you should see consistent scores between test cycles. I'd like to transition to Jennifer, Dr. Howard, and then I'll come back at the end and finish up with some information specific to ACI patients. Thanks.
Hello, everyone. A quick follow-up and clarification before we go on to the next part is on one of those slides about reliability and sources, there was the abbreviation RWS appeared. That was actually a reference to the rhythmic weight shift which was a test we ended up cutting from this presentation due to time. And that the Neurocom, at least our most recent clinical operations guide, doesn't have reliability for that, but we have collected that in our own lab. So if you're interested in that, please let us know and we'll be happy to share that information. What I'm going to talk about now is some of our patient populations that we've looked at feasibility and also the relationship between different types of functional tests, particularly looking at clinical tests to some of the Neurocom measures. Most of the data I'm going to talk about comes from a cross-sectional study that included both preoperative and 6-month postoperative knee surgical patients for a variety of knee surgeries, and also a group of healthy controls. The balance master tests that we utilized were the Unilateral Stance, Step Up and Over, and the Forward Lunge. And then the other test that we used, Dr. Mattacola spoke of, was the 4-score step test, a 30-second step-down test, which was simply a rep count of how many step-downs could be completed in 30 seconds, and also the STAR Excursion balance test in the anterior, posterior medial, and posterior lateral direction. For feasibility, we simply looked at, of our patient groups, how many patients could complete the test. So part of what we were trying to do was develop a functional test battery to track outcomes in our clinical populations. So if our baseline tests couldn't be completed by the patients, then it wasn't going to give us a baseline data point. So we looked at unilateral stance in both the eyes open and eyes closed condition, and 93% of pre-op patients could do eyes open. Everybody post-op and healthy could do eyes open. However, eyes closed, only 86% of the pre-op patients were able to complete, and 88% post-op and healthy. We defined inability to complete the test as having to touch down in 3 consecutive test trials, or an unwillingness to even attempt the test. We had a few, particularly post-op patients, that just weren't comfortable doing the test and opted out of it. For Step Up and Over, 100% of pre-op and healthy patients were able to complete the test. However, 88% of post-operative patients could not complete the Step Up and Over on the involved limb. And we'll talk about that some as I get into our clinical data. That eccentric control and trust of a surgical or an injured limb and the ability to control your mass as you step down from a step is a common everyday problem, and it's also a common clinical problem that we see and does show up in our long force plate data. So the forward lunge, it was our nice intermediate. Everybody in all groups were able to complete the test. The nice part about that is if they can step out any distance at all, it'll give you a data point. So we found that to be our potentially as our workhorse test that everybody could perform at all stages. Looking at relationships to other functional tests, this was a sample size of 48, again, everybody across those 3 groups. Looking at the lift-up index for the Step Up and Over, it correlated to the STAR Excursion balance test, and that was the anterior direction. I think that got left off of here, but and reach distance in the anterior direction to lift-up index. And for time, also correlated in the anterior and posterior lateral, and then also the 4-score step test, the step down, and IKDC. And as expected for reach distances, time with a negative correlation, whereas for the 4-score step test, were in both cases a lower time for the Step Up and Over and the lower time for the 4-score step test are considered better performance. We had a positive correlation. For impact index, we did not see any correlations to our other 3 tests or to patient-reported outcome measure that we used, which was the IKDC, or International Knee Documentation Committee subjective self-report form, where patients report their own level of function on a variety of everyday or sporting tasks. For forward lunge, when we looked at the distance, it correlated to SEDT in all 3 directions with low to moderate correlations, which we would expect because they're similar tasks. And FSST, again, there was a mid-range correlation, and negative, again, better distance versus a slower time, so we'd expect that correlation to be negative. And step-down tests, and again, IKDC, which you'll notice sort of throughout these, that those are our self-report measure matches up very well with our long force plate variables, suggesting that it really is detecting a level of function that's in agreement or closely correlated with what they're reporting. Now, they're not perfect correlations, so we're getting unique information from the force plate, which is a good thing. We've sort of realized that there's no one outcome that answers all the questions. You've got to look across the board from a performance standpoint, from an isolated strength perhaps, and from a self-report and clinical diagnostic outcome. Impact index, again, all three directions for reach distances, FSST, step down test, and IKDC, again, continue to be relatively high to forward lunge. For time, we see the same things again. Again, as time goes down, we see reach distances increase, and also our self-report measures go up as time goes down. What we didn't find were any correlations between unilateral stance, the SIVT, the FSST, or the step-down test, and similarly also with the IKDC, which sort of gets back to the idea that balance is this nebulous concept that may not match up perfectly. It's its own unique variable that needs to be taken into consideration, particularly if you've got somebody that's prone to falling or may have other vestibular issues. To sort of give you an overall picture, if we look at the three groups on bar graphs across the board, for the step up and over looking at time, we can see that there's this relationship where pre-op were slower, post-op were a little bit faster, and then healthy were by far the fastest, with pre-op and healthy being significantly different from each other. For the forward lunge, you see a little bit of the same as far as distance. Pre-op was shorter, post-op went a little bit farther, and healthy went the farthest. With lunge, it was interesting, showing that this may be a test where you can get a data point but still pick up deficits even as people approach higher levels of function. Our pre-op and post-op groups really performed at exactly the same time, but our healthy were significantly faster than both. So this slide gives you a little bit of an overview where the step up and over, we were able to clearly see that there's three different groups trending to develop there, whereas our forward lunge, the performances were really quite similar between the pre-op and post-op, but not the healthy for time. So the forward lunge post-op patients, they're going farther, but they're still not doing it as quick as we would expect in a healthy patient, which makes it nice because you can see the progression when you look at all the variables as a combined picture of patient function. Briefly, these are some of the relationships looking at isokinetic strength. This is from a sample of healthy patients. So for the step up and over lift up index, we saw a correlation with eccentric quadriceps strength. The fact that that's a negative correlation may seem a little bit counterintuitive, but it is very much in line with what we've seen clinically. While that force generated to get up on a step goes up, even when they may have some residual quadriceps weakness. And part of what we think it is it may be a coping mechanism where they're using alternative strategies, perhaps greater gluteal activation, to lift themselves up on a step to compensate for some of those quadriceps weaknesses. For impact index, we again see the negative correlations where as strength goes up, impact index goes down, signifying that eccentric quadricep control as they lower themselves off the step. So with better strength, they've got better control and therefore less impact on the force plate as they come down. Eccentric quadriceps, again, continues to be correlated as expected, and then concentric hamstring, again, maintains that negative correlation at relatively high R values from 0.5 all the way up to 0.78. For the forward lunge, looking at force impulse and concentric quadriceps strength, 0.3 to 0.5, and then also eccentric quadriceps strength, 0.29 to 0.53. Those were the variables relative to step up and over and forward lunge that were significant. In our patient population with cartilage patients, which I'm going to talk about more here shortly, we did not find as consistent correlations. We would find correlations maybe preoperatively but not at 3 months, or maybe at pre-op but not at 6 months. So that clinical population, some of those relationships between different tests and different outcomes seem to vary, and I think that's really a function of the many different variable patient strategies to perform a test that may be out there. The next set of data really gets into some of the clinical applications, and we used the long force plate as one of our outcome measures in a study following autologous chondrocyte implantation patients, or ACI. If you're not familiar with ACI, it is an articular cartilage repair procedure. It's primarily used at the knee. There's some new Taylor research coming out all the time. The knees where it's sort of been the workhorse. And it's a two-step procedure. So briefly, in one surgery, they'll go in, they'll take a sample of non-weight-bearing cartilage from the knee, send it off to the lab, get it cultured, and then a second surgery, use those cultured cells to repair the defect site. The big thing and where it's relevant with this data is it's an extensive rehab following the procedure. So these patients are restricted to non-weight-bearing or limited weight-bearing for 6 weeks to 12 weeks following surgery. So clearly they developed some functional deficits even secondary to the surgery that they may or may not have had preoperatively. This was a sample of 48 patients with an average age of 35. As far as articular cartilage patients go, they were a relatively bigger group with a BMI of 28.5. 25 of the patients were undergoing surgery to the patellofemoral joint with a concomitant tibial tubercle transfer, with the idea being to unload that cartilage on the backside of the patella by anteriorizing that tibial tubercle. We had 2 that underwent surgery to the lateral femoral condyle and 23 that were undergoing surgery to the medial femoral condyle, 4 of which had concomitant high tibial osteotomies to correct some alignment issues with their lower limb, and again, make sure we weren't recreating the cartilage defects that had just been repaired. On average, patients had 1.5 defects with a rather large surface area ranging from 1.9 to 39 centimeters squared. Our outcomes that we used from the Balance Master were the walk across, the weight-bearing squat, the unilateral stance in both conditions, the sit to stand, the step up and over, and the lunge. We also collected patient-reported outcome measures using the IKDC I previously spoke of, the SF36 physical component scale, the Lisham knee scale, and the Western Ontario and McMaster's Osteoarthritis Index, also known as the WOMAC, which is an osteoarthritis-specific disability index. As I get into the results, it's important to remember that the disability index, so a lower score or less disability on the WOMAC, indicates better outcome, whereas the other 3 scores we would like to see going up over time. At each data point, both preoperatively and then 3, 6, and 12 months, we completed our performance-based assessments along with the patients completing the patient-reported outcomes. This is just sort of to summarize our group outcomes, and then we'll go into a little bit more in depth with a couple of case examples. But overall, we saw what we wanted to, with our patient-reported outcomes going up over time, the WOMAC going down over time, and we did have significant improvements from baseline both at the 6 months and at the 12-month time point. Sort of summarize our functional data, what we saw at 3 months was, as I previously mentioned, no improvement in self-reported function. And probably as a result of that non-weight-bearing period, is we saw asymmetry of their weight distribution during squatting. So they were really overloading their non-involved limb and putting below 50% of their weight on their surgical limb. Similarly, when they rose from sitting, that sit-to-stand weight symmetry index was also very asymmetrical, and more asymmetrical than it was preoperatively. So at 3 months, we've almost seen our patients take a backwards functional step. At 6 months, we begin to see improvement in basic activities, such as improved stride length, and we also still continue to see a slowed stepping time on the involved side relative to the uninvolved. And I'll talk about that sometimes, that even though the involved limb may appear within normal ranges, if you look at it compared to what they're doing on the opposite limb or the non-involved limb, it may still show some compensatory strategies, and that what's normal for them they haven't quite returned to. As I said, at 12 months, we had self-reported improvement, which was in agreement with our increased stride length and speed. And as I mentioned earlier, we did see some increase in lift-up force from stepping up on steps, and their lunge time had improved significantly. This is a procedure that it's known that full recovery probably doesn't occur till closer to the 2-year time point. So that we had patients that were happy, we were still slowly seeing progress towards those functional improvements and really getting them back to all of their regular activities. A couple case examples to sort of spotlight some of the information we were able to get from the long force plate with these patients. This was data from a 38-year-old male who's a recreational tennis player. He had a 6-centimeter defect to his medial femoral condyle. At the same time he underwent ACI, he had a concomitant high tibial osteotomy, and he was a relatively sizable gentleman, healthy build, 6'1" and 265 pounds. So to go through some of his force plate data, well, actually self-report, you can see clearly he had a very significant improvement in his patient-reported outcomes, and his WOMAC dropped off significantly over 12 months. As I mentioned, some of the what you would think of as lower demand tests, the walk across speed, we can see progressive improvement across time, whereas our lift-up index and our forward lunge distance are a little more flatline, but again, he started preoperatively in the normal range for these tests. What we can see some lingering asymmetries is his weight-bearing squat. He started really close to that 50% body weight on each limb, and that dropped off over time, and even at 12 months. And this was a case where his pain may have been improved, but he's picked up habits from that period of non-weight bearing where he just simply doesn't use the involved limb to do a lot of everyday tasks. And that's where some coaching and training of the patient to make sure you're not setting that other limb up for problems long-term from a continual overload. And you can see from the sit-to-stand weight symmetry, we see this dip that happens around 3 to 6 months where, again, he's really asymmetrical. But the good news is at 12 months, it looks like he's on a trajectory to get back to more symmetrical loading as he performs that common functional task of rising from sitting. His isokinetic strength testing, I stuck this in here just to give you an idea as to how weak some of these patients really are. And you can see these are side-to-side differences, both concentric and eccentric strength. And he starts out well below 80% and then drops even lower. And again, this matches up with what we're seeing with the weight-bearing squat. He's improving, but he's still not where he needs to be. Another example of a patient is we have a 30-year-old who works as a railroad conductor, which in this patient's case was relevant because he didn't have a high, heavy manual labor job, but he reported to us that whenever the train broke down or there was a problem, he had to functionally be able to walk the entire length of the train from one end to the other. So that being able to walk pain-free and quickly was relevant to him. He had defects to both the medial femoral condyle and the trochlear with a total area rather large of 19 centimeters squared. He actually had both defects treated in one surgery but at separate locations. And he was 5'8", 176 pounds. And the other key thing to think about is he had previous valve microfracture. So this was a patient that was really starting in a hole. The microfracture had only been about a year before, and he'd never gotten back to full activity or recovered fully from that surgery as the microfracture had not taken. And his self-report measures show this very much a step back at 3 months, which is unusual in these patients. Again, they're non-weight bearing, they're not doing much of anything in that first 6 to 12 weeks, and then gradually starting to see slow progress at a very slow state, which is again reflected in his force plate data. His walk across speed dips significantly, and then it's on a trajectory of gradually improving. And similar with his lunge distance, we drop and then he's improving, so it matches up. He's headed in the right direction, just still has some work to do. Now and similarly, his weight-bearing squat still shows these deficits. He was below 50% preoperatively. We were starting in a big hole and gradually starting to get in that general direction post-operatively, both at the 30-degree and 60-degree. And similarly with the sit-to-stand weight symmetry, moving forward at that progression, but it's a slow, gradual one. And interesting, if you look at times, a lot of times you'll see a baseline for the time that looks almost flat because they develop strategies that work, and often with the sit-to-stand weight symmetry, it's doing it on one leg because that's what they did for the first 3 months, so they can do it with pretty high function. That without the force data, sometimes you don't see it. Going back to that side-to-side symmetries, this gives you a little bit of an idea. Looking at this solid yellow line is step up and over, involved lift index. And where I mentioned previously, so this is what his uninvolved limb did. It's almost a straight line with actually much lower force than what he was performing with the involved limb. And that goes back to us thinking there may be some compensatory motions to make up for what he can't do with his quad, that he's trying to use glutes that may actually be exerting a more vertical force down through the box of the force plate, and that may be what's detecting. Similarly, with the involved impact index, we see this big spike at 3 months, which is probably a representation of his lack of eccentric control. And the uninvolved impact index, so the uninvolved impact index is how much force they're putting on that surgical limb. So they step up with the uninvolved limb all the way over the box and land on the involved limb. So sometimes I think of it as a confidence measure. So you can see he's not wanting to put a lot of force or come down very hard on that surgical limb, and then gradually it becomes more, and then probably a balancing back out here at the end. So that's why in some cases it may look okay looking at one side, but if you look at the other limb and make sure you're comparing bilaterally as you would with any physical exam, deficits show up that may not be normal movement patterns for the individual patient. This time I'm going to go ahead and turn it back over to Dr. Mattacola, who's going to present some of the data relating to some ACL patients that they've looked at.
Thanks, Jennifer. Great job. So as Jennifer said, I'm just going to present some data that we have collected in some ACL reconstructed patients. And in this group, in the next few slides, these were on average of 12 months post-operative, and they were compared to control groups. So similar to some of the data Dr. Howard, Jennifer provided relative to the ACI patients, using the step-up and over test, we also found that the lift-up index provided us some useful information. And if you're looking at the definition from Neurocom, it's often described as the maximum lifting force exerted by the leading leg, and again interpreted as that concentric strength. So if you were thinking about somebody that's able-bodied, if they stepped up onto this box, the more concentric force that they could create, then the more, the greater the impact index, or the greater the amount of force that would be generated into this force platform. And that makes sense. And then when we show you some of the patients, I think we have to look at it a little bit differently, because it confused us for a while. We kept taking that definition and saying, well, if it's the amount of force that someone's exerting, and if they're concentric, if they're strong concentrically, then that number should be higher, but that's not always the case. So what we did is we compared this ACL group to a control group, and we found that during the initial step, that lift-up index, it was higher for the control group, which makes sense. So they were potentially stronger. The lift-up index would be higher than the ACL group. That sort of follows the definition that Neurocom, has conveyed, and makes sense if you're thinking about it for someone whose neuromuscular control is possibly not compromised or pain's not an issue. We also looked at movement time in this group, which is the number of seconds required to complete the maneuver. And what we found was the uninvolved extremity was slower than the involved extremity. So when they led with the involved leg, it took them longer to complete the task than when they led with the uninvolved leg. So if we take a look at this, the control group is in green, and the ACL group is in red. And if we look at the control group, they're relatively flat. May have been a little bit faster on what would have been a matched uninvolved leg. So this is the ACL reconstructed leg was involved, and then the uninvolved leg of the ACL group, and then we matched them with the same side to a control group. And the control was age and height, and I think weight matched. And so if you take a look at the ACL group, they were slower with their involved leg versus their uninvolved leg. So movement time and step up in impact index for the step up and over, we found to be useful and indicative if you run the statistics comparing control groups in ACL. For the forward lunge, we also did the forward lunge with this group, and the measure of force impulse, which was the total work performed, we found a significant interaction. And to say that in plain terms, the force impulse was greater for the uninvolved leg than the involved leg for the ACL group. And that would make sense. So if we look at the control group, again, relatively flat with the green line, the measure is force impulse for the lunge. And if we look at the ACL group, the involved leg was less than the uninvolved leg. So the involved leg was significantly different than the control group, and was significantly different than the uninvolved leg. So the uninvolved leg was more closely resembled that of the control group. So again, for lunge test, force impulse and time is useful. So just sort of in summary, in this group, functional testing using step up and over and forward lunge shows promise for assessing quadriceps and lower extremity function. And I really think it's important that not only to use it sort of as a post-operative toward understanding of what's happening at the end of the rehabilitation, but I think many of these tests, particularly the long force plate, when you're looking at comparisons between right and left, are really helpful during the rehabilitative process to use as biofeedback. And we focused more on just trying to understand which one of these provides us better outcomes as we're trying to determine, are we getting patients back where they want to be. A couple little tidbits to throw in. There's a recent study done by Brian Riemann, and using kinematics and kinetics, they examined the role of the ankle, the knee, and the hip while performing the lunge. And what was interesting is they loaded, they placed an external load on these patients of 12.5, 15, and 50% of body weight. And it was determined that the performance of the lunge required more work when you compared it to the hip and the knee. So in essence, that the hip was more involved in performing a lunge than was the knee and ankle, if you look at it from a kinematic and a kinetic component. And that makes sense because when we look at some of our correlations of the lunge and the step up and over, the quadricep strength, and some of the other functional things that we are using, they're okay, but they're not great, so they're not explaining all of the variance. One of the things I caution folks, and myself included, is we've often called these tests assessments of quadricep strength. And I think we have to be careful that while closed chaining activity is great, some of the assessments like a lunge and a step up and over is not all quadricep strength, and there's a large contribution that's coming, probably a greater contribution that's coming from the hip and some coming from the ankle that we're not accounting for. Before I get to the references, I want to add one other thing that sort of helps I think understand how to interpret the impact indexes and lift-up indexes. Is we performed another study a few years ago where we had the step up and over, the patients performed the step up and over and lunge. And in those patients, they were individuals with OA, hip OA, who potentially were coming in for surgical procedure. And we measured several things with the long force plate. And we looked at the stair ascent and stair descent. And one of the things we found is if you looked at the impact index and the lift-up index, that the OA group performed differently than a control group. And specifically, with the lift-up index, they had a greater amount or greater percentage of their body weight that was exerted than a control group. So when they stood up on the box, that percentage of force that was exerted through the box into the force plate was higher than a control group. And this goes back to what Jennifer said. I think depending on the population, we can't just assume that if somebody's able-bodied and that the higher number would be indicative of better performance. In this case, watching these individuals do this, they sort of threw their leg up onto the box and then swung over. And we actually, looking at it qualitatively, would say they had less control and weren't able to exert force in a more controlled fashion. Likewise, in the for the impact index, when they were stepping down with their landing, when they were landing on their involved leg, there was less impact index, which makes sense because they were favoring that limb and not allowing it to bear weight. In addition, what we found, which was in accordance with other research, is that when we had them do the walk across, the length of their stride was less and their speed was less. So they definitely were compromised. They're trying to interpret the force data for the step up and over or the step up and step down, caused us to sort of shake our head a little bit and recognize that it doesn't fit that exact definition that you'll find in the operator's manual for the Miracom. In addition, just to give you an appreciation for this group, we also measured the gluteus medius activity while they were performing these tasks to get a sense of the contribution of that muscle relative to hip patients, particularly those with OA. And they were, their percent of their maximum EMG was approximately 45% versus the control group, which was 20%. So they were using that gluteus medius much more than a control group just to try to maintain their hip position during the step up and step down and during the step length, or the walk across. So I hope that's helpful in providing some of the measures that we've used specifically for long force plate to assess function in postoperative, primarily knee patients. So that's why I hesitated to put some of the hip information in here, but I thought it was relevant to you based on some of the tests that we provided.
Dr. Mattacola, Dr. Howard, thank you very much for that interesting and very informative presentation. I'd like to go ahead and conclude the recorded section of today's presentation.